Yeah, so good morning, everyone. Thank you, AIOC and UC, for having me here. So, I'll be talking about SICS, which is a stepping stone for the cataract surgery. So, I'm not a very good candidate to speak about it as of now because I'm not doing too many SICS, but I'm really grateful that I've learned it during my residency because it comes handy in many of the complicated and tricky situations which you'll end up in. So as we know that in the evolution curve of the eye surgeries is also that we started off with ICCs, then the ECC, and then we went on to the scleral tunnel, the SICS surgery, phaco, and now the latest, the most advanced femtolaser assisted cataract surgery. The curve of evolution is actually very important. So if you go through the curve, then only you learn your basics very appropriately. The scleral tunnel, it was introduced in the 80s for better wound healing to reduce the SIA. So I'll just cover it in three topics. Why it's important for the residents to learn SICS, why for the practicing phaco surgeons, and there are certain additional learnings for the SICS. So SICS is actually has got a steep learning curve, and it is unlike phacoemulsification. There are multiple steps to it, and if you go wrong in any of the steps, then your surgery can get complicated, and you may not get the like the desired results. So for each and every step, you have to be very particular. For the residents, these are certain tips to master your SICS from the initial go. SICS, there are it's a very multifaceted surgery. There are multiple types of incisions, and each of them have their own advantages and disadvantages. There are multiple methods of nucleus delivery in SICS, and which you can try in different situations. And what it does for the beginners is that it gives you a feel of the tissue handling. You learn the biplanar and the triplanar tunnel construction. So it gives you the concept of making continuous rexes. It teaches the residents to deal with the complicated cataract surgeries, because usually these are the cases which are posted for them for ECC and SICS in the initial go. So if you're a phaco surgeon, you're doing your phaco very confidently, why do you still need to know the art of SICS? In certain complicated situations of corneal opacity, scar, adherent leukomas, in very rock hard cataracts which with poorly dilating pupil, fibrotic capsules, those having pre-existing zonular weaknesses, and poor endothelial reserve, these are the situations when you should plan for a primary SICS. Secondly, in certain situations, you may be stuck up during your surgery and you may need to convert your phaco to SICS. There may be wound-related problem, the CCC may run off, there may be an intra-op meiosis and poor visualization, and most of all, there might be a PCR and you want to save off a nucleus drop and a grave situation. So in those cases, you may convert it to the SICS and give a very fine result. So, just see. So, it's just a very small video of recently done SICS which I did after pretty long time. So as you can see, it's a very intumescent and hard brown cataract. So the moment we started with the rexes, even after the aspiration of the milky cortex, the rexes had a runoff and there was an argentinal flag sign. So you ended up with this kind of a complication. So despite this, we could salvage, we could take out the nucleus, we put the foldable IOL in the bag and the rexus margin that we could, and we could give a good result for the surgeon. So the message is that it gives it is a relatively more forgiving surgery as compared to phacoemulsification. Also, some additional points are there. As a glaucoma surgeon, it gives you a feel for the conjunctival wound, conjunctival handling, the construction of a scleral flap, and also you can combine it with the SICS trab in the complex scenarios as in phacolytic and phacomorphic glaucomas. And it doesn't need any sophisticated instrumentation and can be done for the CAM surgeries also. So to wind it up, it's not a dying art. So beginners can get a feel of the tissue handling. It's a savior in difficult situation, can be combined with trabeculectomy, and no sophisticated instrumentation is required for it. Thank you.
Dr. Mainak, and I think let's start with the discussion part of it. I'll start with Dr. Gunjan here. Your call and your discussion as to what would be the better surgical approach.
So, thank you very much, Dr. AIOC, for giving me this opportunity. So, I think Okay, so during the early periods when people are starting with tissue handling, it is better to start with ECC for some people, but now people are directly moving to SICS because SICS gives you the tunnel making and it's a very good procedure so that they can, transition better into phaco. So I think everybody agrees to it. Then transitioning from SICS to phaco is a very good choice because it gives you a lot of, parachute effect that if you are not able to do phaco properly, then SICS may be the choice, or maybe you get a better tissue handling capsular access making. And if sometimes you are not able to do phaco in the back, sometimes get out the nucleus, so they are much more better tissue handling in that. ECC as a cornea surgeon, I would not say it's a bad choice because sometimes we do not have choice, so we have to do ECC for some patients. But I have not done ECCs much. I would have done SICS in few of the cornea patients because now I have learned SICS to that level that I can manage them. But of course, in the trainee, it's a good choice to start with SICS on goat's eye because it gives a very good learning curve for everyone. And you have numbers, especially in charitable institutions. There are so many charitable institutions who have a lot of bulk cataract cases as well. So that's easier and it's a very fast process for them. Yeah. So anybody else can have a discussion on it.
Yeah. Dr. Ipsita, your call on it.
I have personally not done ECC, but when I think about both the procedures, I've done SICS, but when we move on to other surgeries, I feel it is probably better if we would have done both in our residency, because both have some things which we take forward. Probably if we have to choose, once we do phaco, if we still have in certain scenarios, if we have to choose one of these as an option for cataract, then that probably will be SICS. But things like suturing, when you start doing a glaucoma surgery and you're coming across that as the first time, I think it would have been good if I had done ECC and learnt it then rather than learning it while doing a glaucoma surgery. So probably like how our seniors used to do that, ECC, then SICS, even if for a small while, and then stepping into phaco, that would probably make it a smoother run. That's how I feel about it.
Yeah, we have Dr. Aarti here. We had a discussion about ECC and SICS. Your call on it. I think one thing which needs to be discussed is like our seniors, they used to do a lot of ECCs, and from our residency, we are actually subjected to SICS because like initially, I have done initial fight and like we start with ECC, but that suturing becomes another difficult thing for us. And the initial days when we are actually struggling to start with doing an SICS, any of the intraocular surgeries, the hand-eye coordination is not that much. So learning that making a flap becomes slightly better as compared to suturing. This is what my take is. I think I'll ask Dr. Aarti and then we'll close it.
So sorry for being late. I was just in another session. So since I have not heard the talks, my opinion is going to be unbiased. I feel that it is good to have ECC training before having SICS, because I just heard you people talking about sutures. So taking sutures in ECC will help you in future as well. So if in case you want to become a corneal surgeon, you want to take a cornea fellowship, definitely you'll have some idea that how it is done. You will actually know whether I should do cornea or not, because I don't like suturing cornea, so I may not opt for cornea. And if in case you want to, even if you are doing phaco, you want to convert something, you will definitely need suturing. So ECC is something which you should definitely know. So I have done my DNB from South, and I have done 150 ECC before doing SICS, and I feel that has actually helped me. And something which is there's no harm in learning. You may or may not use that, right? And were we discussing also phaco? No. So SICS definitely plays a big role. SICS is a surgery which each one of us should know, whether you are oculoplasty or a retina. I'll tell why. I visit to Africa for community work, and absolutely there is no option of doing phacoemulsification, and SICS was what everybody talks. So SICS is something which is not replaceable, I feel.